GIT, peptic ulcer disease, inflammatory bowel disease, and ulcerative colitis are the 10-mark question which are asked. And also we have upper GI bleeding and malabsorption syndrome only asked once. We are not discussing those topics now. Acute pancreatitis has been asked as 10 markers 2 to 3 times. I request you to go through the surgery topic, that is acute pancreatitis, and we will also discuss under surgery. Under 5 markers, we have acute upper GI bleeding asked many times, GRD asked many times, H. pylori infection asked many times, and peptic ulcer disease asked 4 times, and Zollinger-Ellison syndrome asked 4 times. We have inflammatory bowel disease, ulcerative colitis, and irritable bowel syndrome, which has been asked many times. Along with that, acute pancreatitis is also asked as 5 marker, frequently asked 5 marker. Please go through acute pancreatitis, which is a surgery topic. So first, we are starting the discussion with inflammatory bowel disease. What is inflammatory bowel disease? Inflammatory bowel disease is the chronic inflammation in the GIT due to inappropriate mucosal activation. You'll get to know the meaning of this definition once we discuss etiopathophysiology. Under inflammatory bowel disease, we have Crohn's disease and ulcerative colitis. First, let's see the etiopathophysiology of ulcerative colitis and Crohn's disease. What are the risk factors? The age, we see bimodal distribution. One peak at 15 to 30 years of age and other peak at 70 to 90 years of age. The genetic predisposition, genetic factors leading on to Crohn's disease and ulcerative colitis are, the genetic factors are more pronounced in case of Crohn's, where we see 50% concordance in monozygotic twins, compared to ulcerative colitis, where there is 16% concordance in monozygotic twins. What are those genetic factors which are implicated in causing inflammatory bowel disease? We have impaired innate immunity and autophagy due to NOT2 gene mutations. The NOT2 gene is required for normal functioning of innate immunity, which is reduced in case of ulcerative colitis and Crohn's disease due to the NOT2 mutation. And also, NOT2 normally prevents the invasion of bacteria into the epithelium, GIT epithelium. And also, it prevents the excessive immune response in the GIT. Due to this NOT2 mutation, we see there is impairment in all three functions, which we'll see when we see the pathophysiology of this condition. Then we have syndromes which are associated with ulcerative colitis and Crohn's disease. Those are Turner syndrome, Wiskott-Aldrich syndrome, and then glycogen storage disease type B1. Now, going on to environmental factors which has been implicated in causing inflammatory bowel disease are impaired microbiota in the gut, impaired microflora inside the gut. We have hygiene hypothesis, which states that the intake of nicely stored refrigerated food, which is free of bacterial contamination, reduces the frequency of enteric infections. Due to reduction in frequency of enteric infections, our immune system is not trained. This leads on to increased regulatory response of immune cells in the mucosa, leading on to chronic inflammation and associated damage. This is about the hygiene hypothesis. Then we have smoking as one of the risk factor for inflammatory bowel disease, where we see increased risk of Crohn's disease, and the risk of ulcerative colitis is being seen more in non-smokers. Then we have psychosocial factors which are implicated in causing inflammatory bowel disease. Those are, in case of major life events like divorce, and death, we see increased symptoms in patients, increased symptoms of Crohn's and ulcerative colitis. So psychosocial factors has been implicated as risk factors for inflammatory bowel disease. To all these risk factors, we have pathophysiological process going on inside the mucosa, wherein the impaired function of NOT2 or CAD15 gene causes impaired mucosal immunity, wherein which the innate immunity is impaired. It is inadequate, causing reduced clearance of bacteria from the epithelium, the mucosal epithelium of the GIT. So we see Mycobacterium avium complex and Mycobacterium paratuberculosis inside the GIT cells due to the reduced clearance by innate immunity. The Paneth cells, which are responsible for innate immunity in the GIT, we see in the Paneth cells secreting defensins in a low amount, that is reduced secretion of defensins by Paneth cells, which is also impairing the innate immunity. We also see impaired autophagy in case of inflammatory bowel disease. Due to the impaired innate immunity, our boss, B cells and T cells, get activated. So we have overactive adaptive immunity in case of inflammatory bowel disease, where type 1 helper cells are more activated in case of Crohn's disease, and type 2 helper cells are more activated in case of ulcerative colitis. Due to this activation, we have overactive adaptive immunity causing inflammatory damage in the mucosa, leading on to the clinical manifestations that we see in ulcerative colitis and Crohn's disease. Before proceeding on to discuss clinical manifestations, let me touch upon the pathology, which is very important for understanding clinical manifestation investigations of ulcerative colitis and Crohn's disease. First, let's see ulcerative colitis pathology. Where and all we see ulcerative colitis? What are the sites that we see ulcerative colitis? Mainly, ulcerative colitis involves the rectum, causing proctitis in 50% of patients. We have ulcerative colitis. Please note the ulcerative colitis has superficial, continuous, and symmetrical lesions. The lesions are not skipped in ulcerative colitis. So we have rectum and sigmoid colon being involved in 30 to 40% of patients. We see pancolitis along with proctitis in case of 10 to 20% of patients. And also we see backwash ileitis in 10 to 20% of patients, wherein the terminal 2 to 3 centimeter of ileum is involved in ulcerative colitis. We see the ileum is more involved in case of Crohn's disease. But in ulcerative colitis, we only have backwash ileitis. That's it. Now, what are the gross findings that we see in inflammatory bowel disease? In the early course of disease, due to inflammatory damage, immune damage, we have erythematous mucosa and granularity in the mucosa, followed by hemorrhagic edematous ulcerative lesions. These lesions are superficial, involving mucosa and submucosa of the GIT, that is colon and rectum, and the lesions are continuous. You can see the lesions are continuous and they are symmetrical. So we can see hemorrhagic edematous ulcerative lesions, which you can see here. This is the normal mucosa, this is the diseased mucosa. After this, following ulceration, the mucosa will proliferate, it will regenerate. It may lead on to, upon regeneration, it leads to occurrence of pseudopolyps, which are seen in ulcerative colitis. So pseudopolyps are seen in chronic cases where due to mucosal regeneration. In long-standing cases, the patient having ulcerative colitis for many years, we have lead pipe appearance, characteristic lead pipe appearance on radiography, where the ostrations are lost. The normal ostrations of colon are lost. Along with that, due to fibrosis, there is shortening of colon. That is called as lead pipe appearance seen in ulcerative colitis. And also the dreaded complication of ulcerative colitis, we can have toxic megacolon, where the diameter of colon will be more than 6 centimeters. It may perforate and cause peritonitis, very deadly condition. Now, these are the gross features of ulcerative colitis. Let's see the microscopic features that are seen in ulcerative colitis. We see superficial involvement involving mucosa and submucosa, in contrast to Crohn's, which has transmural involvement. In the mucosa and submucosa, we see plasma cells, T cells, and macrophages in the lamina propria and mucosa of the GIT. It is associated with cryptitis. On histopathology, we can notice cryptitis. What are the crypts? Crypts are nothing but microscopic invaginations. The GIT mucosa. Here you can see crypts, intestinal crypts. This may get involved, thereby causing cryptitis. By that cryptas abscess. And also characteristically, please note, there is loss of crypt architecture in case of ulcerative colitis, and the crypt architecture is intact in case of Crohn's disease. Along with this, we see Paneth cell metaplasia in ulcerative colitis. Now let's proceed on to discuss the pathology in Crohn's disease. First, let's see gross. Crohn's disease can involve anywhere from oral cavity to anal canal. Most commonly, it involves ileum and colon, causing ileocolitis in 40 to 50% of patients, followed by isolated ileitis in 30 to 40% of patients, followed by isolated colitis in 15 to 20% of patients. The lesions in Crohn's disease are deep, transmural, asymmetric skip lesions, in contrast to ulcerative colitis, which has continuous superficial lesions. Now, what are the gross findings that we see? Initial course of the disease, we only see superficial aphthous ulcer. Following that, the patient will develop linear serpiginous ulcer. Linear serpiginous ulcer. This linear serpiginous ulcer may fuse horizontally and transversely, leaving behind the normal mucosa in between, which is seen as cobblestone appearance. Due to the inflammation in the GIT, the mesentery can get thickened, leading on to creeping fat appearance, which is seen in Crohn's disease. And also in the perirectal region and other sites, we can note abscess, fistulas, and fissures. We know the lesions in the Crohn's disease is deep. It involves transmurally all the layers of GIT mucosa up to the serosa, causing fissures and fistulas. Following these lesions, it goes into fibrosis. Fibrosis causes thickening and strictures in the GIT mucosa. These strictures may cause obstruction, and this thickening and strictures gives rise to typical garden hose appearance in Crohn's disease. This is about the gross findings in Crohn's disease. What are the microscopic findings seen in Crohn's disease? We have transmural involvement, the deep ulcers, fissures, and fistulas. The deep ulcers can reach up to the serosa, causing fissures and fistula, which are seen on microscopy. We have non-caseating granuloma, which are not seen in ulcerative colitis. The crypt involvement causing cryptitis, crypt abscess, but the crypt architecture is intact in case of Crohn's disease, in contrast to ulcerative colitis. This is all about the pathology seen in Crohn's disease and ulcerative colitis. So let's see the clinical manifestations seen in ulcerative colitis and Crohn's disease. The clinical symptoms is characterized by first severe attack, followed by relapses and remissions, which are seen in weeks and months. The relapse is precipitated by stress, emotional stress, and gastroenteritis. During this attack, we have intestinal and extraintestinal manifestations. First, we are discussing the intestinal manifestations. Those are, in case of ulcerative colitis, we see proctitis in 50% of patients, leading on to painless bleeding per rectum, which is the most common presentation, followed by proctosigmoiditis, which causes streaks of blood in the formed stools, followed by, due to proctocolitis, the patient may have large bowel diarrhea that is frequent small volume diarrhea, for frequent small volume stools along with the blood, mucus, and pus. And the patient associated with this has tenesmus. These are all the intestinal manifestations seen in case of ulcerative colitis. Along with this, some patients, only some patients, complain of crampy lower abdominal pain. So let's see the intestinal manifestations in Crohn's disease. We see the most commonly we see ileocolitis leading on to episodic right lower quadrant pain. Characteristically, this right lower quadrant pain will disappear after the patient passes stools, that is after diarrhea. Here we saw in Crohn's disease that type 1 helper cells are more active, leading on to systemic manifestations like fever, etc. Just due to release of inflammatory mediators like interleukin 2 and in INF gamma, that is interferon gamma. And also the patient will have weight loss and cachexia due to these inflammatory mediators. We can see jejunoileitis in case of Crohn's disease, leading on to malabsorption, which also contributes to weight loss seen in these patients. The patients with Crohn's disease, since they have transmural involvement, the GIT can go into bowel obstruction, or also following stricture formation, the GIT can go into bowel obstruction, leading on to features of acute abdomen, where the patient has acute onset of constipation, the abdominal distension, etc., and acute onset of abdominal pain. The 30% of patients have perianal fissures, fistula, and abscess. So also the patients with Crohn's disease can have palpable inflammatory mass. We have the inflammation going on in the GIT mucosa. Due to that, GIT mucosa will get thickened. We also have creeping fat in case of Crohn's disease. So on palpation, we can palpate inflammatory mass in Crohn's disease patients. These are all the intestinal manifestations in ulcerative colitis and Crohn's disease. Let's see the extraintestinal manifestations in ulcerative colitis and Crohn's disease. What are those? We can divide it into extraintestinal manifestations seen in both disease and seen only in Crohn's disease. Seen in both diseases are systemic amyloidosis, the eye manifestations like uveitis, scleritis, and also involving joint we have ankylosing spondylitis, sacroiliitis. Involving skin we have erythema nodosum and pyoderma gangrenosum. These skin manifestations are more marked in Crohn's disease. In Crohn's disease specifically, we have osteomalacia and osteoporosis as extraintestinal manifestations. These are all the clinical manifestations that we see in ulcerative colitis and Crohn's disease. Let's see the management of this condition. How to investigate and treat this condition. The investigation we can divide into common investigation, the investigation findings which are common in both ulcerative colitis and Crohn's disease, and also investigations findings which are specific in ulcerative colitis and Crohn's disease. First, let's discuss what are the common investigation findings that we see in both of these diseases. On blood investigation, in both of these diseases, we see anemia, raised DSR, and raised WBC count. These two are due to inflammation. Anemia due to loss of blood, the hemorrhage, and also associated vitamin B12 deficiency seen in these patients due to malabsorption. Then we have on serology, we have anti-Saccharomyces cerevisiae antibody, that is against the yeast, in 40 to 70% of patients of Crohn's disease. In 10 to 15% patients of ulcerative colitis, we see anti-Saccharomyces cerevisiae antibody, ASCA antibody. We have anti-goblet cells antibodies and anti-Pianka positivity in case of these patients. These are the common investigations findings seen in both ulcerative colitis and Crohn's disease. Now, what are the specific ones that we see in this disease? In ulcerative colitis, on stool examination, we do stool culture and microscopic examination in case of ulcerative colitis to rule out Clostridium difficile which present similar to ulcerative colitis with diarrhea and passage of stools with blood, and also large bowel diarrhea. To rule out Clostridium difficile infection, we do stool microscopy and culture. The stool markers like calprotectin and lactoferrin are positive in case of ulcerative colitis. In fact, this positivity can be used to confirm the relapse of disease in some patients. The gold standard investigation for confirming ulcerative colitis and Crohn's disease are endoscopy with biopsy. On sigmoidoscopy and colonoscopy, we note all the gross features that we discussed previously in ulcerative colitis, like superficial ulcers, pseudopolyps, hemorrhagic edematous mucosa, etc. On biopsy, we see the microscopic findings that we discussed, like Paneth cell metaplasia, cryptitis, cryptasis, loss of cryptactic architecture, etc. The radiological features that we see in ulcerative colitis are toxic megacolon, which we already discussed. On barium enema, we can see fine granularity, superficial ulcer. If the ulcer are little bit deep, we can see collar button appearance. And also we see, due to loss of ostrations and fibrosis, we see lead pipe appearance in ulcerative colitis. In Crohn's disease, on endoscopy, we can see on colonoscopy and sigmoidoscopy, we can see the findings like serpiginous ulcer, which we already discussed, strictures, fistula, fissures, and also the cobblestone appearance. And biopsy, we see non-caseating granulomas, cryptitis, cryptapsis, and ulcers, fistulas, etc. What are the radiological findings in Crohn's disease? On barium meal, we can see actus ulcer, fistulous tract, cobblestoning, and also string sign. String sign is when long segment of colon is fibrotic. It appears as string, called as string sign of Cantor, seen in Crohn's disease. Now, these are all the investigation findings that we see in ulcerative colitis and Crohn's disease. Let's see the treatment that we do in ulcerative colitis and Crohn's disease. Ulcerative colitis, we have true love and Witt's classification, classifying ulcerative colitis as mild, moderate, and severe disease. In mild disease, the patient have less than 4 stools per day with absence of fever, tachycardia, anemia. And in severe disease, we have more than 6 stools per day with passage of blood, and also the patient will have fever, tachycardia more than 90 beats per minute, anemia with ESR more than 30. In between mild and moderate disease, the disease is called as mild and severe disease, the disease is called as moderate disease. The mild disease, we give mesalamine, which is delayed release or controlled released ASA. It's an anti-inflammatory drug. 5-ASA, that is anti-salicylic acid, 5-ASA, mesalamine. So as maintenance, we can give topical 5-ASA. In moderate patients with moderate disease, we give oral mesalamine with steroids. Here we don't give steroids. Here we add on steroids. And if the patient is refractory to oral mesalamine and steroid, we can give azathioprine or 6-mercaptopurine. And also for maintenance, in case of moderate disease, we give topical 5-ASA and azathioprine or mercaptopurine. Here we only give topical 5-ASA in mild disease. In moderate, we add on azathioprine and 6-mercaptopurine. For severe disease, we give IV steroids and anti-TNF alpha agents or IV cyclosporin for managing the relapse. After that, followed by maintenance dose of azathioprine or 6-mercaptopurine with IV TNF alpha inhibitors or oral cyclosporin. This is about the treatment of ulcerative colitis. This is the treatment of Crohn's disease. The Crohn's disease is divided into mild to moderate disease, moderate to severe disease, and severe to very severe disease, or severe to fulminant disease. Mild to moderate disease, we don't see dehydration, we don't see weight loss, we don't see intestinal obstruction and systemic features. In severe to very severe disease, we see fever, obstruction, and cachexia. And also we can see peritoneal signs due to obstruction, and it may be due to the peritoneal signs like peritonitis leading on to acute abdominal distension and abdominal pain can be seen in severe to fulminant disease. In mild to moderate disease of Crohn's disease, we give oral budesonide. That's it. That is 9 mg per day. No maintenance dose is required in case of mild to moderate disease. Only oral budesonide is enough. In moderate to severe disease, we give oral steroid. Along with that, we give methotrexate and anti-TNF alpha agents. Anti-TNF alpha agents are infliximab, adalimumab, and cetolizumab. And also for maintenance, we give 6-mercaptopurine or azathioprine with methotrexate with periodic anti-TNF alpha agents. See, in moderate to severe disease, we are giving 3 drugs during management of relapse and followed by 3 drugs in maintenance. In severe to very severe disease, have the patients, the patients will, in these patients will give IV steroids, and also we give IV anti-TNF alpha agents like cetuximab, adalimumab, and infliximab. For maintenance, only periodic anti-TNF alpha agents are sufficient in these patients. This is about the treatment in ulcerative colitis and Crohn's disease. To summarize, inflammatory bowel disease is a chronic inflammation involving GYT due to inappropriate mucosal activation. We have Crohn's disease and ulcerative colitis under this. The idea of pathophysiology, the risk factors, we have the age, we have bimodal peak, that is one peak in between 50 to 30 years, second peak between 70 to 90 years. The genetic factors we saw is more pronounced in Crohn's disease. Those are NOT2 mutations and syndrome, Turner syndrome, Biscott-Aldrich syndrome, and glycogen storage type D1. The environmental risk factors like altered microbiota in hygiene hypothesis, where due to consumption of well refrigerated food which is not contaminated, the frequency of enteric infections are reduced, with impaired training of our immune cells, which leads to increased regulatory response in the mucosa, leading on to inflammatory damage. The smoking we have in smokers increased risk of Crohn's disease. The non-smokers have increased risk of ulcerative colitis. The psychological factors, psychosocial factors are also been seen to increase the symptoms of this disease. The pathophysiology, we saw there is mutation of NOT2 gene which leads to impaired mucosal immunity, that is impaired innate immunity causing reduced clearance of bacteria, impaired secretion of defenses by Paneth cells, and impaired autophagy leading on to overactive adaptive immunity, overactive B cells and T cells. In Crohn's disease, we see more type 1 helper cells activating. In ulcerative colitis, we see type 2 helper cells being activated more. This leads on to inflammatory damage, overactive adaptive immunity. Then we saw pathology, the ulcerative colitis gross. Here the lesions are superficial, continuous, asymmetrical, mostly involving rectum and rectosigmoid region. And also we can see pancolitis. Initially we see erythematous mucosa with granular appearance, followed by hemorrhagic edematous and ulcerative lesions, followed by pseudopolyps due to mucosal regeneration. On long-standing case, we can see lead pipe appearance and toxic megacolon. On microscopy, we see superficial involvement, that is in mucosa and submucosa infiltrated with T cells, B cells, plasma cells, and macrophages in the laminopropria. And also we see cryptitis with loss of crypt architecture with Paneth cell metaplasia. In Crohn's disease, we see the gross appearance. Here, the lesions are deep, transmural, and asymmetrical skip lesions. We see after cells are initially followed by linear serpiginous cell which fuse to form which fuse horizontally and vertically, and then it leaves the areas called as normal area which gives cobblestoning, and then we have creeping fat. In the perirectal region we can see fissures, fistulas, and abscess, followed by fibrosis which leads to thickening and strictures, leading on to the characteristic garden hose appearance. The Crohn's disease can involve anywhere between oral cavity and anal canal. The microscopy, we have transmural inflammation, non-caseating granuloma, and cryptitis and cryptapsis with no loss of crypt architecture. Under clinical manifestation, we saw in ulcerative colitis, we see intestinal manifestations like painless bleeding, PR, streaks of blood in stools and large bowel area. In case of Crohn's disease, we saw malabsorption, fever, weight loss, systemic symptoms, and episodic right lower quadrant pain, which is the most common presenting symptom. And also extraintestinal manifestations, we saw ankylosing spondylitis, sacroiliitis, uveitis, scleritis, systemic amyloidosis, erythema nodosum, pyoderma gangrenosum, and osteoporosis. The investigations findings common to both. We saw blood investigations and serology. The specific investigations, we saw two markers, calprotectin and lactoferrin, seen in ulcerative colitis on endoscopy. Endoscopy and biopsy are the gold standard investigations done in ulcerative colitis and Crohn's disease. The radiological features, we see toxic megacolon on Barian enema. We can see collar button appearance and blood appearance in ulcerative colitis. And endoscopic and microscopic findings similar to pathological findings which you have already mentioned. We can see serpiginous findings, serpiginous ulcer strictures, fistula. On biopsy, we see non-caseating granuloma. On radiological examination in Crohn's disease, we see on Barian lemma, after ulcer, fistula, tract, cobblestoning, and sting sign of Cantor. The treatment we saw in ulcerative colitis, we classify true love and WITS classification, mild, moderate, and severe disease. In mild disease, we give mesalamine followed by topical 5-ASA maintenance. In moderate disease, we give oral mesalamine and steroid followed by azathioprine and 6 mercury of purine if it is resistant to this. The maintenance, we give topical 5-ASA and azathioprine or 6 mercury of purine. In severe disease, we give IV steroid with anti-TNF alpha agents or IV cyclosporine followed by azathioprine 6 mercaptopurine and IV TNF alpha or oral cyclosporine maintenance. In Crohn's disease, we classify as mild to moderate disease, moderate to severe disease, and severe to very severe disease. Mild to moderate disease, only oral budesonide 9 mg per day is enough. In moderate to severe disease, we give oral steroid methotrexate with anti-TNF alpha agents, and maintenance we give 6 mercaptopurine or azathioprine with methotrexate and periodic anti-TNF alpha agents. In severe to very severe disease, we give IV steroids and IV TNF anti-TNF alpha agents. For maintenance, we give periodic anti-TNF alpha agent. This is about inflammatory bowel disease. Thank you for listening.